Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Millions of Americans take pills, drugs for pain, blood pressure, heartburn, or cholesterol. Can you ever stop taking such medications? This is the People's Pharmacy with Terry and Joe Graydon.
Doctors are accustomed to prescribing medications. The idea of deprescribing is relatively new. When is it safe for a doctor to take a patient off a drug they've been taking for some time? How can you tell if the risks of a medication outweigh the benefits?
Many drugs can't be stopped suddenly. Withdrawal symptoms can be extremely uncomfortable or even life-threatening. How can doctors and patients come up with a personalized plan to taper off gradually?
Coming up on the People's Pharmacy, we welcome your questions and stories about deprescribing.
First, this news.
In the People's Pharmacy health headlines, cancer is the second leading cause of death in the U.S., right behind heart disease. Between 1980 and 2014, death rates from cancer fell about 20% overall. That's good news, but there are plenty of regions that are being left behind. The study, published in JAMA, included more than 19 million cancer deaths between 1980 and 2014. Lung cancer death rates were particularly high in Kentucky. The study was not able to distinguish whether smoking or coal dust exposure was responsible for the high rate of lung cancer deaths in the eastern part of the state. Although prostate cancer death rates dropped in much of the nation, Owsley County, Kentucky saw a 26% increase. Other areas of the South also had higher rates of fatalities from prostate cancer. Similarly, breast cancer death rates dropped in the Northeast, Northern Midwest, and Southern Florida. They remained high along the Mississippi River, especially in the South. The author suggests that prevention and screening programs may be falling short in these regions.
Is it smart to block stomach acid production with powerful proton pump inhibitor drugs? Researchers in Scotland have found that acid-suppressing medications such as dexlansoprazole or esomeprazole make people more vulnerable to gastrointestinal infections. Their review of the records of 500,000 Scots showed that those taking PPI medications were about 1.5 times more likely to come down with Clostridium difficile than those not on such heartburn drugs. C. difficile can cause hard-to-treat diarrhea. People on prescription PPIs were also about 4 times more likely to pick up a Campylobacter infection. The investigators warn that these powerful drugs should not be used casually.
One of Finland's favorite pastimes may benefit the brain. Previous research showed that middle-aged men who frequented a sauna several times a week were less likely to die of heart disease. When people come out of the sauna, they often have lower blood pressure, which may partially explain the cardiovascular benefits. Further examination of the records shows that frequent sauna bathers were also less likely to develop Alzheimer's disease or other dementia. Those who visited the sauna more than 4 times a week were 66% less likely to be diagnosed with dementia than those who visited only once a week. Adjustment for exercise and diet did not change the association. Visiting a sauna is a social activity in Finland, so that may also help contribute to the value of time in the sauna.
High blood pressure is considered an important risk factor for dementia as well as heart disease and stroke. But a new study suggests that if blood pressure rises late in life, it might actually ward off dementia after 90. Investigators tracked more than 500 nonagenarians for almost 3 years. None had Alzheimer's disease at the outset. People who developed hypertension after their 80th birthday were 42% less likely to be diagnosed with dementia in their 90s. Those who developed high blood pressure after age 90 were 63% less likely to end up with serious cognitive decline. Hypertension was defined as blood pressure higher than 140 over 90. The researchers speculate that higher blood pressure in very old people may help keep blood flowing to the brain so it stays adequately supplied with oxygen. The older adults in the study who had higher blood pressure were also less frail.
Almost 2/3 of Americans take at least one prescription medication daily. 1/5 take more than 5 different doctor-prescribed drugs. That doesn't include any over-the-counter medications or dietary supplements. A study in JAMA found that older people are especially vulnerable to complications. More than 1/3 of emergency department visits for adverse drug events were made by people over 65. Anticoagulants and diabetes medicines were especially troublesome in this age group. Because prescribers and pharmacists may not always take the time to check on drug interactions, patients and their family members should ask whether any of the pills they're taking might be incompatible. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
I'm Terry Graydon. I'm a medical anthropologist. There are an estimated 8 million adverse drug events that occur every year in outpatients, and many of them are preventable. The more medicines you take, the greater the likelihood is that you'll experience some side effects or interactions. 20% of American adults take 5 drugs or more that their doctors have prescribed every day. That doesn't count any dietary supplements or over-the-counter medicines that they take on their own. In Canada, it's quite similar. 70% are taking more than 5 drugs, and 10% are actually taking more than 15.
Not infrequently, people get caught in a vicious cycle. A statin to control cholesterol may cause muscle pain or arthritis. That could lead to taking a pain reliever like ibuprofen that in turn causes indigestion, high blood pressure, and atrial fibrillation. Those symptoms could lead to an acid-suppressing drug like Nexium, a blood pressure pill such as lisinopril, and an anticoagulant like Xarelto. Each of these may have its own set of side effects for which additional medications are added.
Well, to find out what we can do in such a situation, we turn to our guests. Here in the studio today, we welcome Dr. Mitchell Heflin. He is Associate Professor of Medicine and Senior Fellow in the Center for the Study of Aging and Human Development at Duke University Medical School. Welcome to the People's Pharmacy, Dr. Heflin.
Thank you, Terry. It's great to be here.
We're also pleased to welcome Dr. Laura Hansen. She is professor in the Division of Geriatric Medicine at the Center for Aging and Health at the University of North Carolina at Chapel Hill. She's also part of the UNC Palliative Care Program. Welcome, Dr. Hansen.
Thank you, Joe. It's a delight to be here.
Dr. Hansen, what could be done in a case like the hypothetical instance that Joe just outlined? Would it be helpful for the patient to stop taking some of those medicines, and how would you approach that?
That's a great question. And I have to say, as a geriatrician, that the description of the case sounded really familiar to me, something that we see in practice every day. Our first approach is to take a comprehensive look at the whole patient and try to understand that chain of events that led to the prescribing, but also try to understand the chronic health conditions that the individual has that might merit medical therapy, as well as their goals and priorities, what it is they're looking for from healthcare. I think of deprescribing in 2 ways. The first is urgent deprescribing, paying attention to urgent concerns of adverse medication effects that the individual can't afford to keep living with. And the second is really to think of it in a preventive sense. How can we simplify and focus the use of pharmaceuticals?
Well, I think simplification is a great idea, because when I read that 10% of Canadian elders, and I should have said this was in people over 65, 10% of Canadian elders are taking 15 or more medications, and I'm thinking, how do they keep them all straight? Even if you're not 65, it would be hard to keep 15 medications straight. And as you get older, that gets more complicated. Dr. Heflin.
Yes, I completely agree with that assessment. And I would add that one of the biggest challenges we have in this circumstance is getting accurate information about medications. And so in approaching deprescribing, actually the first step is to get a clear idea and documentation of actually what medications a person is really taking and linking those for at least their perception of the indication. And given the number of prescribing providers, given the number of pharmacies involved, often this can be very difficult and involves a team approach. Team meaning not just the person taking the medicines, but their loved one, the pharmacist, and other team members in the office.
We'd like to invite our listeners to join the conversation. What has been your experience with multiple medications? Have you ever had trouble stopping a drug? If you'd like to share your story or ask a question, you can call 888-472-3366. You can email us, radio@peoplespharmacy.com, or get in touch via Twitter. We're at People's Pharmacy. That number again to share your story or ask a question, 888-472-3366.
Dr. Heflin, Dr. Hansen, we have asked you here today to talk about deprescribing. That's not a term most of us are familiar with. Which of you would like to define it for us?
I'll volunteer
Thank you.
Then welcome Dr. Hansen's additions to my definition. Actually, I'm going to chicken out and go to an article that first appeared in 2015 in JAMA Internal Medicine that helped me to clearly define the process of deprescribing. And it really described it as a systematic process of identifying and then discontinuing medications where the risk would ultimately outweigh the potential benefit. And that incorporates a careful consideration of a patient's goals of care, their medical problems, their current level of functioning and life expectancy, and ultimately their values and preferences.
Now, before we go too far down this road of deprescribing, I want to say that there are medical conditions where you just cannot stop. And I always worry that, we're talking about medications that may have great risks. But you take a situation where someone has an irregular heart rhythm, for example, whether it's atrial fibrillation or something more serious, or someone who has heart failure. If the person isn't taking their medication correctly, that could lead to all kinds of complications.
That's exactly right, Joe. And that's a great example that kind of mixes these two aspects of deprescribing. If an individual has atrial fibrillation, they're likely to be on an agent that slows their heart rate. Say diltiazem, for example, and they might have a side effect from diltiazem like a lowering of blood pressure or constipation. And they're also likely to be on a blood thinner, which has certain risks related to the risks of bleeding that come along with a blood thinner. But our job in deprescribing is to take a look at that medication profile and that illness profile and ask in conjunction with the patient, is it better and safer to stay on the current medications? Is it better and safer to adjust the doses downward in order to ameliorate some of those potential side effects? Or is it better and safer to actually taper off one of those medications?
Well, for example, the scenario that I created in the beginning was someone who was on a statin. And, if you follow the guidelines and you're a physician, almost everyone over the age of 70 should be on a statin. But if that person develops muscle pain and weakness, and then they start taking ibuprofen in large doses on their own, and that causes atrial fibrillation and indigestion. So now we have a cascade of things, and each of those drugs can cause, in their own way, serious complications.
So I just want to emphasize here, when we talk about deprescribing, we are talking about the patient and the doctor working together, not the patient doing this on his or her own.
That's absolutely right.
So everybody these days knows a little something about the electronic health records because they're, ubiquitous. You can't go into a hospital or a clinic without them. And you always get asked what medicines you're taking. And there's somebody who is very diligent, oftentimes a nurse, entering all of your medicines, all of your dietary supplements, herbs, vitamins, whatever it may be. But I wonder, does anybody ever bother to check if there's incompatibility?
So actually, that's a topic I'm so glad you raised. It's one that I was thinking about prior to the show. One of the great things about the electronic health record, used correctly, is that medication list is more often attended to than it was in our old paper records. And furthermore, in modern electronic health records, we actually have some of the important drug interactions built into the computerized system so that when a prescriber goes to order a new medication, a potential interaction warning is given and allows the prescriber to pause.
And I would add to that the electronic medical record in many cases allows a person or a loved one to go in and actually look at what we have on file themselves. And I'll routinely encourage the folks that I see to go in and look at their record and make sure that it reflects what they're actually taking and to inform me if that's the case.
Now, that's the good news. The bad news is something called alert fatigue, where there are so many alerts, so many warnings, so many interruptions in a busy clinician's schedule, whether it's the prescriber or the pharmacist, they're overridden. That's the little secret that people often don't know.
Yeah, this is a real issue. And you mentioned the real issue is time. And I would say this is where what Dr. Hansen mentioned about prioritization. And so we know that, in fact, there are situations where there's urgency for deprescribing. We also know that we can look for particular medications that cause problems more frequently than others. And I'm sure we'll get into published lists that are available and approaches that can help us prioritize those medications.
Well, we have just about enough time to say the name of a couple of published lists, and then we'll have to go to the break. So what lists?
So there are really, and this is for the provider, there are two lists that we primarily use in geriatric care. The Beers criteria, which were published in the 1990s, and the Stop-Start criteria.
And Beers is spelled B-E-E-R-S. Well, we do need to take a short break, but when we come back, we're going to talk more about polypharmacy and deprescribing.
Have you ever experienced a problem that was solved by stopping a medication?
Have you ever had trouble getting off a sleeping pill, an antidepressant, or a heartburn medicine like omeprazole?
You can share your story or ask a question. Our lines are open, 888-472-3366. You can send us an email, radio@peoplespharmacy.com. Get in touch through Twitter. We're at People's Pharmacy, 888-472-3366. You're listening to the People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to the People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Redx Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number is 800-345-7339. The website is uttercream.com.
If you would like to purchase a CD of this show, you can call 800-732-2334. It's show number 1066, or you can find it online at peoplespharmacy.com.
Today we're talking about how to avoid over-medication. One important tool that doctors have at their disposal is deprescribing. We invite you to share your story about medication side effects or the vicious cycle syndrome. Our number, 888-472-3366. If our lines are full, you can email us, radio@peoplespharmacy.com, or you can get to us via Twitter or at People's Pharmacy. You can ask a question of our two experts. The number again, 888-472-3366.
And we go to a call from Joseph. Welcome to the People's Pharmacy, Joseph. Your question?
Thank you. Yes, I actually have an experience to share. A couple of years ago, I was on a statin for cholesterol, and I was having memory problems, and heard on your show that we had that it was a memory issue, that the cholesterol in the brain was important. And so I asked him if I could stop it, and he did some calculations and said, well, it will increase your chance of heart disease very slightly, but sure, let's try it. And I stopped the statins, and I started having much better memory issues, or less memory issues. Mostly it was a situation where I couldn't grab the word that I needed, and that I was starting to actually keep track of how frequently it was happening. It was happening multiple times a day. And now, after a couple of years off the statins, and also advice from your show about increasing fat in my diet, I'm not sure which was most significant, but now the problem is almost completely gone, and I'm 67.
Joseph, thanks so much for sharing that story. And we really appreciate the fact that you went to your doctor and asked the doctor, would it be okay if we tried this out? We are talking today with Dr. Laura Hansen. She's a professor in the Division of Geriatric Medicine at the Center for Aging and Health at the University of North Carolina at Chapel Hill. She's also part of the UNC Palliative Care Program.
Our other guest is Dr. Mitchell Heflin. He is Associate Professor of Medicine and Senior Fellow in the Center for the Study of Aging and Human Development at Duke University Medical School. Now, we sometimes get a little blowback from physicians who say, don't mess with success. Joseph, his cholesterol was great. He was doing fine. There's no evidence that statins affect the memory. That's probably all in his head, pardon the pun. How do you deal with the don't mess with success message that I'm sure you hear sometimes from your colleagues?
The really important strategy, I think, is to recognize that as physicians, we want to help our patients, and the way we've been trained to help is to give a prescription. That is our hammer, and we see a nail. We can learn new practices, and one of those new practices is deprescribing, is understanding that our job is to prescribe wisely and to balance prescribing with deprescribing. Statin therapy is medication to prevent adverse events in health in the future. It's a preventive intervention using a medication, and as such has modest individual benefit, especially for individuals who don't have established heart disease or prior cardiovascular events. So it's a great opportunity for this kind of shared decision-making about the pros or the cons of continuing.
Well, I'd like to share an email with you. We had to take our mother to the hospital because she'd fallen and broken a rib. Part of the admitting process was listing all the meds she was on. The hospitalist who saw her reviewed the list and said, "Why is she taking such and such medications? We didn't know just what had been prescribed to help her sleep at night." The doctor said these meds can make the elderly fall, and that such drugs should not be given to a person who is 80 years old. We're now attending doctor visits and taking notes. We're trying to have her see just one doctor and use one pharmacy so there's better oversight After she was discharged from the hospital, we had to endure her benzodiazepine withdrawal. But how can we learn what other drugs one should avoid? Dr. Heflin?
So I think this is a important and all too often anecdote. And it is true that there are certain medications in older adults that come with red flags. We've alluded to a couple inventories of medications, one being the Beers list, the Beers criteria, which outline a list of potentially inappropriate medicines for older adults. There are shorter inventories that actually provide more detailed information, one of which comes from the American Board of Internal Medicine and the American Geriatric Society. It's part of the Choosing Wisely campaign, and I would point folks to this list, one of which concerns use of sleeping medications, particularly benzodiazepines.
Such as?
Such as lorazepam, diazepam, commonly known as Valium.
Alprazolam, commonly known as Xanax.
That's correct. And again, the idea that these cause cognitive problems, sedation, and falls, and those have been clearly linked by research evidence. But the other part of this message is that in reviewing medicines and noticing particularly benzodiazepines, it's clear that they can't be stopped necessarily abruptly and need to be done in a monitored setting, one, to prevent withdrawal symptoms, and the other, if the problems with sleep return or problems with anxiety for which it was being used return, then there needs to be a structured approach to addressing those symptoms.
Now, of course, one of the problems is that one of the symptoms of withdrawal is anxiety
right.
and insomnia. So people get caught up in the, is my insomnia and anxiety returning, or is this withdrawal from the drug? Speaking of withdrawal, we will go to Dallas, Texas. Justine, welcome to the People's Pharmacy. What is your story, please?
Hi, guys. So my story is I've been on and off. Well, I guess I've been trying to find a really good antidepressant, kind of mood stabilizer since I was 13. And a couple years ago, I found Cymbalta, and everything was going great. And then all of a sudden, I missed a prescription, and the withdrawal was just beyond words terrible. And I ended up looking it up online and finding an entire community of people complaining about the fact that the withdrawal was so bad that they were starting to call it a disorder, a disease, trying to come off of it, and that people were just unable to come down without getting very, very sick. And I guess I'm a little worried now, just, that my doctor didn't say anything about it, and it does work, but like you guys say, the side effects are just really troubling.
Justine, what kinds of symptoms did you experience when you missed some pills?
Oh my gosh, dizziness, nausea, hot and cold sweats. I mean, it was bad. I think I had the flu and had to go to the hospital and everything, and it was worse than that. And it would come in and out while I was at work, while I was at school, and it's terrible. Now I'm still on it because I quite honestly just can't get off of it. I can't even taper on it because the withdrawal is so bad.
Dr. Hansen, deprescribing a drug like Cymbalta, how do you go about that? Because as Justine has pointed out, this drug can be very difficult to get off.
Justine, I'm sorry to hear about the withdrawal experience, but I'm so glad that we're talking about this. It's so important for people to understand in the audience. And the prior email addressed it as well for a different class of drugs. Deprescribing for many classes of drugs involves a very careful and very thoughtful approach to tapering. And tapering a medication needs to be done in conjunction with a physician and needs to be done at the pace that the individual can tolerate. The journey can be very long with tapering of antidepressant medication.
One of the problems that people sometimes encounter, and I'm not remembering right now if this is true for Cymbalta, is that there may not be small increments of the medication may only be available in one dose or maybe 2 doses, which makes it harder to taper. Well, what can you do in a case like that?
So I think one important factor is to go back and to review how effective the medication has been and to understand the reasons for taper and withdrawal. There are different approaches to also, depending on the situation, whether you're simply trying to decrease a medication to discontinue or to decrease while adding a different medication to replace that medication. It's a very complex process, and I would recommend routinely consulting with a pharmacist to understand the pharmacology and to come up with a plan of either spacing, dosing, or going to, as I said, longer intervals may be one alternative.
Rather than cutting down on the dose.
Now, I don't know if this is true for Cymbalta. Duloxetine is the generic name, but there are some antidepressants that come in capsules. And what people have done, because they have experienced such unpleasant withdrawal symptoms, they have literally opened the capsule and removed the little pellets inside on such a gradual basis.
One at a time, essentially.
So that it might actually take 6 months to a year for them to actually get off the drug completely. Now, that seems almost bizarre that it would be that slow a taper. But for some people who are super sensitive, it has to be much slower than a week, 2 weeks, or even a month.
And I would emphasize that this is a customized process. And likely the most important ingredient for success is a very strong working relationship between the provider, the prescribing provider, and the person who's trying to taper the medication. An open line of communication, expectations, and I think a sense of that it's not failure if symptoms return. And I emphasize for patients that I'm not emotionally tied to any result other than you feeling better, and that I just want to hear about those symptoms.
And I think the point you're making is this is personalized.
Right.
There is no one size fits all. And there are no guidelines that are going to work for everyone who's trying to get off alprazolam or Cymbalta or any one of the number of drugs. In fact, one that most people have not even thought of is something called tramadol, because this is a pain reliever, and they think, well, pain reliever, it shouldn't be a problem, but it also has an antidepressant component. So it can be a real challenge to get off certain drugs, and it may take some people a lot longer than others.
And if I could just add a thought to that, realize that all of our research, or almost all of our research, teaches us how to start medications. We have very, very few research studies that teach us how to taper and discontinue medications.
Oh, thank you so much. That's such an important point. We do have an email with an interesting story. My sister and I were very concerned about my 73-year-old aunt and the tremendous number of medications she was on. She was in a terrible nursing home and was continually strapped in a wheelchair. She was always agitated and often spoke to people who had been dead quite a while. The doctor said her hallucinations were caused by a stroke and dementia. Her family was in complete denial. My sister got your guide to drugs and older people and the drug safety questionnaire. These are actually things that we offer on our website for free. We moved her to a different facility 2 weeks after the medicines were stopped or the doses were lowered. She has become herself again. Thank you for helping us get our wonderful aunt back.
So you deal with palliative care. We have heard this story before where someone is almost on the edge of saying goodbye to the world, and everybody says, well, let's just take them off all medicines. It doesn't matter at this point.
They're, how long are they going to survive?
The
Not
statin is no longer relevant. And all of a sudden, there's cognition, there's recognition, the person is back. Have you heard of such a thing?
Absolutely, Joe. From my work in palliative care, which is specialty care for people with serious illness, which is often life-limiting illness as well, we are, like those working in geriatrics, very concerned with rational use of medications and avoidance of side effects. And I hear from my colleagues who work in hospice about these episodes anecdotally. The individual was admitted to hospice, acknowledged as completely terminally ill, and when coming off medications, got better. Those are anecdotes. The vast majority of individuals with terminal illness will not have that experience, but it's very important to keep those anecdotes in mind.
Well, that brings me to this idea of if someone is in their 80s or 90s and they're on the verge of hospice, do they really need to be taking 15 different medications?
So it is a question of what are the ingredients to making rational decisions about use of medications. One of those is understanding goals of care and life expectancy. And I think, as Dr. Hansen mentioned earlier, is this a preventive measure or is it a symptom management measure? And how does that then inform how we use it? I think the other is understanding how these medications have been layered on over time and what are the barriers to actually deprescribing. And perhaps we can talk about that in a little bit, but sometimes going to a visit with a loved one and expressing concern and giving permission to think about how to peel off medications is really critically important.
Here's an email that we received from Kitty, and she says, after taking Nexium for a couple of years, which had been prescribed after my perforated ulcer, probably caused by meloxicam, a drug, an NSAID for arthritis or pain, it took me 6 months of slowly decreasing the dose to get off it. I ended up taking the powdered form in very small doses, and happily I am off it now. Most people would never think that you would have to taper a heartburn medicine, a proton pump inhibitor.
Kitty, that's a really important story, and I'm so glad that you are raising a story about proton pump inhibitors, which are now one of the most commonly prescribed classes of medications in the United States. And I notice in the People's Pharmacy News at the beginning, we also heard a story about these medications. These are medications that are now widely prescribed, even though when they first came out, they were intended to be used short term. It's important to think about how people can get off of these medications.
When we come back, we're going to find out about blood pressure and dementia.
Can blood pressure go too low in older people?
And we invite you to join the conversation. Our lines are open at 888-472-3366. You can email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. 800-345-7339, online at uttercream.com.
If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1066, or visit our website. It's peoplespharmacy.com.
Today, we're talking about how to combat overmedication by deprescribing. Our lines are open for your stories about too many medicines and the trouble they could cause. Do you have a question for our guests about how to stop medicines that might be unnecessary or counterproductive? You can call us, 888-472-3366, email radio@peoplespharmacy.com, or get in touch through Twitter. We're at People's Pharmacy. The number again, 888-472-3366.
We're talking with Dr. Laura Hansen. She's professor in the Division of Geriatric Medicine at the Center for Aging and Health at the University of North Carolina at Chapel Hill. She's also part of the UNC Palliative Care Program.
We're also talking with Dr. Mitchell Heflin. He is Associate Professor of Medicine and Senior Fellow in the Center for the Study of Aging and Human Development at Duke University Medical School. Dr. Heflin, the barriers to deprescribing, what are they?
So this is critically important to understand, Terry, and it comes from both sides, from the prescriber and from the people who are taking medications and their family caregivers. From the prescriber's side, I think it's important to understand there's actually relatively little evidence, that is research evidence, to inform the benefits of prescribing and how exactly we do this in a step-by-step process. I think also there's a lack of time. We talked about this before. It takes time to discuss and come up with contingency plans for deprescribing. I think as well, there's a sense of when there are multiple providers, particularly, there's prescribing, what I call prescribing inertia, that I'm afraid to stop this lest something bad should happen. From the perspective of the person taking the medicines, very similar issues of inertia. What if I stop this medicine and something bad should happen? There's also a sense of disrupting the relationship of trust between me and my provider, that if I call into question a medication, is that calling their competence into question? And I would argue just the opposite. We often welcome those invitations to discuss and deprescribe.
This brings back a memory from 25, 30 years ago. A woman said that she was concerned about hormone replacement therapy. She had been going through menopause, and her doctor just insisted that she needed HRT. It was going to be good for her skin, take away the wrinkles. It was going to be good for her brain. It was going to be great for her bones.
This must be before the study came out.
That's before the Women's Health Initiative. And she finally decided that she was going to stop taking the hormone replacement therapy because it made her nervous. She had heard these whispers about breast cancer and heart attacks. And her doctor said, "You're fired. I'm firing you. You cannot be my patient. If you won't take HRT, you're out of here." And she was really incensed. How can my doctor fire me? Well, he did. And so there is that sense of trust that if I challenge my doctor, I will be questioning him somehow and he will fire me. And how do we overcome that kind of obstacle?
So I think from the physician or prescriber's perspective, it requires an invitation and a sense of partnership. And some of that comes from that initial step of please bring all your medicines and all your concerns about your medicines. So it's placed as a priority on that. And then starting with thinking about maybe single medicines and concerns about single medicines and taking these on one at a time in the course of a visit, I think then makes it seem like a reasonable endeavor.
Shall we go back to the phones? Let's go to Abilene, Texas. Evelyn, welcome to the People's Pharmacy. Your comment, please.
Thank you. Hi, Joe and Terry. I can't tell you how happy I am that y'all are back here in Abilene, Texas. There was a short time when I couldn't get your show, and I just hated it.
Oh, well, thank you, Evelyn. We're delighted to be back with you.
Yes, thank you. My experience is I'm a 30-year healthcare veteran, retired, and I help a little lady. She's in her 80s. I've had several issues come up with her medications because I pay very close attention. And last year she fell, and when she fell, she went to the hospital, and they put her on a new med. I can't remember the reason because I get lost in the translation. Sometimes the family won't tell me everything the doctor said. So they put her on a new medication, and in 6 months, when we went back for her regular checkup, they told her blood was something was wrong, and they were going to send her to an oncologist. Of course, that scared her to death. She lost her dad to leukemia, so So we took her. I called the pharmacist, and I said, this new drug, I said, would it interact with any of the other 13 medications she's on? And he said, well, it could. That's all he'd say. And so I told the doctor, and he said, well, okay, stop it until you see the oncologist and see what he says. So I stopped it, and we took her in. We couldn't get in. It took about a month to get in. And when we went in, he said, your blood is just right on the border. He said, I really can't do anything unless it gets worse. He said, but we'll just watch it. I said, okay. So I told him the situation. He said, that's fine. Just, let me know what the next blood thing does after you go to your regular doctor. So we went back. The blood was perfect. I said, oh, well, you don't need to go. It's back to normal. But nobody ever said, I think it could have been that. They just didn't pay attention to it. So I want to affirm all these commenters that are saying they want to, or are not sure how to check on their elderly relative or family member or whoever. People need to know. They need to know what their loved ones are on and why.
Absolutely, Evelyn. We couldn't agree more.
Thank you so much for the call.
Yes, thank you.
The story that Evelyn points out is a terrific one, and I know that one of our mantras in the practice of geriatric medicine is first think drugs. Not in the street sense, but in the prescribing sense, in the sense that we need to understand always what the potential adverse effects are. And that medication review is a core practice in geriatrics, and something that if an individual's primary physician is unable to provide, is something that one may be able to seek from a geriatric specialist.
And I would add, Evelyn, thank you for your advocacy. Frequently, it's critical, particularly if folks don't have a family member, to have someone, perhaps even with a healthcare background like yourself, who can advocate. Again, that's really important.
So I'd like to bring up a very controversial topic, and it's controversial in part because we have been taught, I think both patients as well as health professionals, to follow the guidelines, the recommendations that have been brought forth by the wise, greater, knowledgeable people in the field. And one of the areas that's been particularly interesting to us is blood pressure. We are told over and over again, correctly, that hypertension increases the risk for heart disease, strokes, kidney disease, dementia, all kinds of problems. So you've got to get your blood pressure under control. And for a lot of people, that's 120/80. That's sort of the magic number. But as people get older, what we have heard is that in their 80s and sometimes in their 90s, aggressive blood pressure control, especially when the diastolic blood pressure gets down around 70, that it may actually increase the risk for dementia. And there's a study that just came out this week, Terry.
Yeah.
And it suggested that in 80 and 90-year-olds that higher blood pressure may actually be associated with a lower risk of dementia. So how do you walk that tightrope between preventing a stroke on the one hand or dementia on the other because of too aggressive treatment of hypertension?
So we often in geriatrics are thinking about balancing all the time. Another way to think about it is like a Goldilocks phenomenon. Not too little, not too much, but just right. And with many common chronic conditions, hypertension, hyperlipidemia, or too much cholesterol, diabetes, we are seeking the correct balance so that we don't overcorrect an abnormality and cause further complications. In this case, in the study of hypertension, which was an observational study, it's certainly possible that some of that effect is explained mechanistically. It's good to have a little higher blood pressure when you have some atherosclerotic changes in the brain because circulation to the brain is improved. It's also possible that some of it is explained epidemiologically, in that we know when individuals are close to the end of life, they typically have lowered blood pressure, and that could explain some of the findings.
And of course, Joe, you did say, but I want to re-emphasize that the people who did better if their blood pressure was higher are people whose blood pressure didn't start to get higher until after they were 85.
Exactly.
I might add one additional point, as Dr. Hansen has pointed out. Physiology changes with aging. That's a critical point. And we know that blood pressure is not one number, that over the course of the day it can fluctuate dramatically or even with body position. With every visit to the office should do a blood pressure sitting and standing. And I'd say in my office, almost more often than not, there's a significant change, particularly in the top number called the systolic blood pressure. We're treating a range and need to account for the lowest range and the upper range. That becomes very important.
Let's go to St. Petersburg, Florida. Mary, welcome to the People's Pharmacy. What is your story or question?
Good morning. Thank you. So many of the things you talked about, I could talk about every one of them. But basically, I called to talk about knowing when to get off medication. And my problem is that doctors seem to want to give you another drug every time you go in with a symptom. I had a heart attack, open heart surgery. I have heart disease and cancer on both sides of the family. So doctors are always treating that. I'm on metoprolol and had been prescribed a statin, which early on, which I didn't take because the muscle pain was horrible. Finally, my doctor had talked me into taking a very, very low dose, so he says, of a statin, because then it could help me. And I don't know sometimes whether I'm having indigestion or am I having the symptoms of a heart attack, because my heart attack, they were very similar. And so then I go into the doctor and say, this is my dilemma. So he prescribes the isobride monotrate. And I looked at the symptoms, the side effects, and I'm saying, well, this is what makes me want to take this drug in the first place. How am I supposed to know whether I'm having a heart attack or indigestion? These are horrible side effects.
So, Mary, your question is basically, how do we distinguish between the side effects of the medication and the underlying condition that she's worried about? Dr. Heflin?
This is very often a problem, and I hear your dilemma. I think it's going to be very important in your case to work carefully in a stepwise fashion with your physician and to understand how to respond to those symptoms at any given time. Of course, I imagine it's frightening, and you need a mechanism by which, if you have that symptom, you know how to respond. Again, this gets back to understanding symptoms up front and how to communicate about them, and then how to prioritize. Is this, for example, is this a medication that's going to improve or reduce my risk of heart attack versus is it treating a symptom per se, as we talked about earlier? Again, I think an open exchange with your physician will help both avoid problem symptoms and help you kind of work this out.
So this gets to the problem of how to evaluate whether or not a drug should be deprescribed.
That's correct. So how do we prioritize medications for deprescribing? And I think we can start with the idea that, does each medicine really have an indication? Or, so perhaps it's a medicine that doesn't really have a problem, or the problem has resolved. Or is it part of the prescribing cascade that Joe mentioned earlier, and that we need to work back through that cascade? Or is the medicine simply one more on a list, and I'm making a choice, knowing the risks and benefits, that's not a medicine that I want to take? And then perhaps there are cost issues or logistics that make it more difficult.
Dr. Hansen, how can a person find a doctor that will help them with deprescribing?
as I mentioned a little earlier, looking for a geriatrician for people who are in the older age group, you are very likely to find somebody who has expertise in deprescribing. Another suggestion that I make to many patients who are wrestling with medication issues is to recognize, perhaps assist your physician to recognize that it is completely acceptable to have an entire appointment dedicated to medication review. You can spend an entire clinic appointment at your request reviewing your medications, discussing potential adverse effects, and prioritizing.
And let me just get up on my soapbox. I can't help but do it with that message, and that is, we need more geriatricians in this country.
Yes.
We couldn't agree more.
And you need to be paid more. I mean, it's the people who do stuff, the cardiac surgeons who get paid a ton of money. The geriatricians are deprescribing, and you don't get paid for taking away medications. And as those aging baby boomers start to develop some health problems, they're going to need your help really badly. So let's hear it for more medical students aiming for becoming geriatricians.
Hear, hear.
That's all the time we have. Thank you so much for listening. And thanks to our guest, Dr. Laura Hansen. She's professor in the Division of Geriatric Medicine at the Center for Aging and Health at the University of North Carolina at Chapel Hill. She's also part of the UNC Palliative Care Program.
Our other guest has been Dr. Mitchell Heflin. He's Associate Professor of Medicine and Senior Fellow in the Center for the Study of Aging and Human Development at Duke University Medical School.
Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. 800-345-7339. Online at uttercream.com.
And if you'd like to order a CD of today's show, you can call 800-732-2334. Today's show is 1066. That number again, 800-732-2334. On the web at peoplespharmacy.com.
When you go to peoplespharmacy.com, you can tell us what you think about the show or find information on prescription drugs, herbs, and home remedies. You'll find a list of anticholinergic drugs on our website. When you stack up those anticholinergic drugs, they can affect your brain function. For a limited time, you can get our guide to drugs and older people for free.
And a list of Beers drugs, BEERS, inappropriate for older people. You can also subscribe to the free podcast of the show. It's all there at peoplespharmacy.com. I'm Joe Graydon.
I'm Terry Graydon. Thanks for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
When a shopper places an order, you have one shot at winning them as a lifelong customer. I'm Al Coe, CEO of ShipStation. I'm obsessed with ShipStation being the most reliable and efficient way you can ship. At ShipStation, our promise is to make shipping easier for e-commerce business owners. We're focused on providing the most integrations with all the places you sell and automating manual tasks to make fulfillment easier for your team. We partner with all the major carriers to make sure you get the lowest possible rates because every dollar counts. So no matter what you're sending or where you're shipping to, ShipStation can get it there fast and keep your customers happy. See for yourself how ShipStation can reduce the time and effort you spend on order fulfillment. Go to ShipStation.com to sign up for your free trial. That's ShipStation.com.